that today. And before I turn it over to Dr. Aurora, I just wanted to just give you an overview of the agenda, what we'll be talking about today. Dr. Aurora is going to start with talking about giving you an overview of Project ECHO and the ECHO model. We're going to talk about ECHO's impact, the growth of the movement, and then, of course, as we all know, on March 11th, all of our lives changed. And we at ECHO feel that Project ECHO plays a very special role and has a very special role to play in responding to COVID-19. We're going to talk about our work addressing COVID-19, and then we want to share some partnership opportunities with you. And then, of course, we're going to open it up to questions and for discussion, and we invite you all to join us for that. And I also wanted to just tell you that this is being recorded. This session is being recorded and will be available to everyone in about 2 days on the Catalyst 2030 site. And so without further ado, I'm going to turn it over to Dr. Sanjeev Arora, the founder and director of Project ECHO. Dr. Arora, over to you.
Thank you, Cynthia. And it's an honor and privilege to be here. I'm going to speak for a little over 30 minutes and but look forward to discussion with you about the ECHO model and how we can partner with you to improve healthcare in your communities. So one of the challenges we have is that people all over the world don't have access to good healthcare because the right knowledge doesn't exist at the right place at the right time. So I'll start with a story of how this affected me. The year was 2001, and I'm a gastroenterologist by profession and a professor at the University of New Mexico. I had gone into my clinic and I saw a patient there, and she was a 43-year-old woman, and there were 2 children sitting in the room with her. So I asked her, how can I help you? And she said, I have hepatitis C and I want treatment. So I said, how long have you had this? And she said, I've had hepatitis C for 8 years. So my next question was, why did you not come earlier for treatment? We've had treatment for the last 8 years. And she said, you know, I live 200 miles away, and I'd called your clinic, and there was an 8-month wait to see you. I was told that I would have to make 12 trips to see you here. And there was no way I could do that. I couldn't take that much time off work. My car is old, and I would have to take my children out of school. So I decided I would just not get treated. So I said, why did you come today? And she said, I came today because I'm having a lot of pain in the right upper side of my abdomen. So I did an ultrasound of her abdomen and found that she had a liver cancer, which was slightly smaller than the size of a tennis ball. And it was too big for us to remove surgically, and it was too large to do a liver transplant. And she passed away 5 months later, leaving these 2 children. So I asked myself this question. I said, why is it that I'm living in the United States where all the treatments are available and the medicines and the testing is available, but she was not able to access treatment? Why did she die? And the answer was, she died because the right knowledge didn't exist at the right place at the right time. This was a really key insight for me, that even when finances exist, you need the right knowledge at the right place at the right time to get the right care. Otherwise, that would be impossible. And as I studied this later, I realized that this problem was being replayed all over the world continuously, that millions of people were dying because of this knowledge problem. In India alone, for example, 1,100 people were dying every single day. And you can see worldwide that number is close to 500 of TB. But I'm picking on India because the medicines are for free, the diagnostic tests are available, and yet people die of a curable disease. In Africa, 1 million people die of pneumonia, again treatable, bronchitis. 1,800 children die every year for diarrheal disease. This is truly unacceptable. And that's why we've started ECHO. And the challenge, of course, I was facing in my clinic was that there were 28,000 patients who had been diagnosed with hepatitis C and less than 1,500 had been treated. And the challenge for me was, how do I get all these people on treatment at the same time, quickly, so that thousands would not die? And there were no specialists in rural areas. So at ECHO, our mission is to democratize medical knowledge and get best practice care to underserved people all over the world. And our goal is to touch the lives of 1 billion people by 2025 by moving knowledge instead of patients and providers. So going back to hepatitis C, what happened is I said, okay, let me test if I have a good model. I'm going to treat everyone who wants treatment in New Mexico. And then I would have a model for complex disease in rural locations in developing countries. So this is the ECHO model. There are 4 key ideas which stand up the model. One is amplification, that is using one-to-many video conferencing to leverage the expertise of a multidisciplinary team of experts, in this case, a gastroenterologist, a liver specialist, and infectious disease, and pharmacy. The second key idea is to share best practices. So I went around the state of New Mexico and we set up 21 new centers for treatment of hepatitis C in New Mexico. 16 were in rural areas, 5 were in the prisons, and each was run by a primary care clinician. And I gave them my protocol and said, now I'm going to teach this to you. Can you treat hepatitis C? And they said, no, this is chemotherapy. We are not willing to do that. We are not trained gastroenterologists, and this is risky business. So I asked myself, how did you become an expert? So when I was doing my fellowship in gastroenterology in Boston, this is what happened. I would see a patient, I would present to my professor, I would see another one present to my professor, and I kept doing this for 2 years, and after which they started calling me a gastroenterologist. So I said, aha, I'm going to use this model to create new hepatitis C-ologists in New Mexico. The third key principle is what I talk about, case-based learning or iterative guided practice. This is the key insight that we have in ECHO, that if you essentially do iterative guided practice, very much like you teach your daughter to drive a car, or I got trained in my residency, what will happen is you will take a novice and make him an expert. And the last principle is to use a web-based database to monitor outcomes. So what we do in ECHO is we train these physician assistants, nurses in hepatitis C, train them to use our web-based software, which tracks the project. And then we conduct these tele-ECHO sessions called knowledge networks. So this is what a knowledge network looks like. So starting in 2003, what we started doing was we said, okay, all 21 of you join forces with us to treat these 28,000 patients that exist. And I'm going to make you experts. So they would join once a week, Wednesday from 3 to 5 p.m., and one by one present patients to each other and to us at the university. And we would help them manage these patients. And everybody had a chance to comment. And we would use about 15 minutes of our time to give them a lecture on some aspect of hepatitis C that we wanted to. But most of it was we were managing real cases. We call this idea a learning loop. And we found that in 1 year, these people became total experts. The wait in my clinic actually fell from 8 months to 2 weeks in about 18 months of doing this. And everybody in New Mexico could get treatment. We asked ourselves, how did they become experts? And we described a concept called a learning loop, that they were learning from us, they were learning from each other, but mostly they were learning by doing. They were learning from each other because they were bringing one patient to the network a week, but they were learning on 10. And the wait in my clinic fell because first they treated their own patients and then they started accepting referrals from everybody else in the community, and everybody got treatment. Thousands of people got treated. So one question, of course, I asked was, why would these people join? Why would they spend so much time? We were giving them CME credits, nursing credits. We gave them professional interaction with colleagues of similar interest and gave them access to multiple specialists at the same time. So one of the questions, if you ever mentioned echo, with people will raise the issue is, what's the difference between echo and telemedicine? So in telemedicine, there's a specialist in black at the bottom helping a patient in blue. This is a very useful thing for patients because they don't have to travel. They can be at home. And some of you may be aware that more than 60–70% of all the visits in the world right now are occurring on telemedicine, either telephone or video, because of the COVID-19 pandemic. But ECHO has a different goal. ECHO is teams of experts training teams of local providers in community clinics who then help hundreds and then thousands of patients. So ECHO is about giving, traditional telemedicine is about giving people fish. ECHO is about teaching people to fish. ECHO is a capacity building tool. The only technology a rural clinician needs is a webcam or internet access. If they have that, everything else is provided by us at the Project ECHO Institute. And I offer these technologies and resources to all of you who want to partner with us. So you would have a Zoom platform, which we would give you at no cost to you. You would have the video recording system, where you could record these sessions and then replay them, analyze them, and we would give you software. And my colleague, Kent, is on this call today. We would give you access to the Project ECHO Resource Library, which he catalogs and maintains, where intellectual property from people all over the world who do ECHO is housed for sharing openly with the world. It contains things like, the resource library contains things like protocols, evaluation tools, PowerPoint presentations, curricula, etc. So the first group of studies we did in our hepatitis C ECHO was to study self-efficacy. Scale here is 1, I have no skill, 7, I'm an expert who can teach others. And we took these 25 clinicians and said, what's your ability to identify candidates for treatment for hepatitis C? 2.8 out of 7, went to 5.6 in 12 months. Question 3, ability to treat hepatitis C and manage side effects, went from 2 to 5.2. Can you now manage psychiatric comorbidities? Because there were no psychiatrists in New Mexico, and interferon, the treatment, the chemo-like treatment, was causing depression. 2.6 to 5.1. Can you now become a local consultant and actually accept referrals? 2.4 to 5.6. Overall competence went from 2.8 to 5.5. The next step was we had to prove that these doctors could do as good a job as university specialists. So we did that, and we published this study in the New England Journal of Medicine to demonstrate that these primary care clinicians in rural areas and prisons could give chemotherapy and get the same results as us without any specialists being there, as safely and effectively, and we can improve access to care for minorities. So we took these 21 clinics I talked about earlier and compared them to the control University of New Mexico liver clinic in a prospective study. And the principal endpoint was a lifelong permanent cure of the virus. This would add many, many years to any patient's life if we did that. And these are the results. The outcomes were that the cure rates in the university and the ECHO were identical, and more people got treated, more minorities got treated, many more in ECHO versus university. So we concluded that rural primary care clinicians deliver Hep C care that is as safe and effective as a university, and we can improve access to care for minorities. And we then the next step was we could use this for many, many diseases. So we said, look, if the disease is common, if management is complex, new treatments are coming, if there's a high societal impact, if there are serious outcomes of untreated disease, and if you can improve outcomes with effective treatment, then you can use this model. And we started using it for 70 different healthcare conditions. First, we started one for diabetes, then for HIV, then for rheumatology, chronic pain, opioid addiction, and so on and so forth, heart disease. All this while, as we were rolling out Echo around the world, we kept evaluating it. And you can see here, we currently have, actually the latest number is 235 peer-reviewed publications in the literature, demonstrating the effectiveness of Echo. 62% show that providers like to attend and learn. 21% show, that's about 50 publications show, that quality of care improves, workforce training occurs, access to care improves, and other things mentioned here. We also have programs to train community health workers because we believe that chronic disease management is a team sport. If you're living in Africa, you're not going to have enough doctors to take care of all the patients. So you need nurses trained, you need community health workers trained in areas like diabetes and substance use and mental health disorders, asthma, so that these community health workers can then go ahead and train patients, educate them, support them. Our goal is to help 1 billion people by December 31st, 2025. So how do we do that when only 2.2 million people live in New Mexico? So what we decided was we would train any university or nonprofit organization in the world that wanted to deploy the Echo model. We would give them all our technology. We would do all this for free. And we would really set them up to replicate Echo. We would give them the technical assistance they needed, the software, access to the resource library. And that essentially, we started training other universities. And so now we have 234 hubs in the United States. Pretty much every major university has already launched Echoes. Many large non-government organizations like American Academy of Pediatrics or American Cancer Society, and universities like Harvard and Yale and Johns Hopkins and University of Texas, University of Washington, Stanford, UCSF, University of Chicago have all launched Echoes. And we do, as I mentioned, Echoes for 70 different disease areas. Worldwide now, we have 401 hubs in 41 countries. And you can see we have hubs in New Zealand, in Australia, in Vietnam, Myanmar, Japan, Kyrgyzstan, Kazakhstan, India, Pakistan, Georgia, Germany, Denmark, Ireland, UK, many hubs in Africa, which I'll talk about in a bit. We have hubs in Latin America, many of them, and in the United States. We also have what we call super hubs that train other hubs to Before COVID-19 came, we looked at our growth, and you can see at the bottom right of this slide that our growth has been sort of doubling every year. And as I mentioned, we have 401 hubs in 41 countries now. But what we found was that there were 121,000 clinicians being mentored in 25,000 organizations in the world, in 158 countries. And we had, on average, 6 attendances per person for 92 minutes. I want to talk a little bit about Africa. This is Echo in Namibia for getting a couple of 100,000 patients of HIV on treatment. This is Windhoek, where the expert team is sitting. This is one rural hospital learning. Now, of course, in the COVID-19 world, we cannot allow 20 people to sit in one room in a rural hospital and learn. That would have catastrophic consequences. But our technology that we provide to our partners will allow each of these learners to be at home. 1,000 people would be able to join, to learn, if you wanted to, on the technology that we provide. This is one rural hospital learning. In addition to, as Cynthia mentioned, in addition to just treating disease, Echo is being deployed for a lot of other things in the world right now. For example, in quality improvement, we use Echo for laboratory strengthening, rapid HIV testing, viral load scale up, quality improvement programs, antimicrobial stewardship, infection control prevention, outbreak management, emergency preparedness, safe surgery, cancer, and so on and so forth. The one other thing that Cynthia mentioned was this issue of use of Echo in education. This is a very rapidly growing area for us. As you're aware, a lot of the education in the world for school students is moving in the virtual environment. And a lot of teachers all over the world are not capable of really delivering a very high quality product virtually yet. They haven't been trained to do that. So that's one area that Echo is working in a very extensive way. Another area is training them on STEM, math, science, education. How do we make mentor teachers to work at the very highest level? That has been the focus of education Echoes in the world. In Africa, we have lots of Echoes, but we need hundreds more. So if you are living in Africa and are interested in helping your community, either in education or in healthcare, and especially if you want to help your countries for the COVID-19 response, reach out to us. But right now we have 28 one-country programs, 2 in Namibia, 5 in Kenya, 5 in Tanzania, Uganda, Ivory Coast, Nigeria, South Sudan, and others. On March 11th, the World Health Organization declared COVID-19 a pandemic. And we know that this is not just a public health crisis. This is also an economic crisis. This is a social crisis. People are isolated. Every sector of humanity has been affected. In countries which are low income, there's increased starvation. Vaccination rates have gone down. Economies are disrupted. And we all have to respond very robustly if we want to control this epidemic. So in Echo, we have now got a very large number of COVID-19 responses. We have basically tried to pivot as much of our Echo hubs. As of last count, 140 hubs are doing COVID-19 response to amplify the public health response and amplify the care response. So what do we mean by amplifying the public health response? This is training people for testing, training them for contact tracing, for isolating patients. Then once you found the contacts of those index cases, you want to quarantine the contacts, and then you want to test these quarantined contacts. When they become positive, you have to contact trace their contacts. You have to teach the community how to use personal protective equipment. In Brazil alone, 152 doctors have died of COVID-19, more than 500 nurses. In the United States, the CDC just reported more than 9,000 professionals, healthcare professionals, have died of COVID-19. We want to amplify the care response, telling doctors how to manage a patient as an outpatient. When you get him in the clinic, how to protect your other patients. How to manage chronic diseases other than COVID-19 when you can't get patients into your clinic. How do you manage inpatients? How do you create a COVID-19 floor so that the whole hospital doesn't get infected? How do you manage how much oxygen does a patient need? Too much is bad for them. Too little, they can die. What is the ventilator setting should be set up? Should you ventilate them in the stomach or the back? And every day, this knowledge is changing. 2 days ago, a new study came out from the United Kingdom, literally day before yesterday, showing that if you use corticosteroids for seriously ill COVID-19 patients, you could reduce their death rate by either 20% if they needed oxygen, or almost a third if they were on a ventilator. So what are we doing? We have trained 500,000 clinicians, but we need to train millions. We've trained them in 158 countries, but we need to do many more. We need to do every country in the world. And if you have an interest in this area, please reach out to my colleague Cynthia or to me. On the last slide is my contact information. So these are our partners in the United States who are already doing COVID-19. You will have access to my slides, so I'm not going to read these, but I wanted to put them in there because you can then approach these if you have an interest. These are our international partners who have launched COVID-19 echoes. As I mentioned, a total of more than 140 are there. Very, very many people have endorsed the use of echo. For example, the World Health Organization in the African region is our partner. This is a quote from Dr. Swaminathan, showing that echo can be a very useful way to expand COVID-19 response, and others. These are the countries where we are using echo for COVID-19 response, but we barely touched the surface. This COVID-19 problem will be bothering the world for at least another 18 months to 2 years. A lot of work has to be done. We have to train communities on how to respond. We have to train healthcare workers on how to be resilient in the face of death, in the face of sickness. For the young healthcare workers, they have the concern that they will take COVID-19 back home to their parents, because in most parts of the world, people are living in joint families. Parents are living in the same household. These challenges, we need to work together. We need to partner globally to make a difference. Let's look at what India has done with COVID-19. Over the past 12 weeks, they have trained 282,000 participants, done 835 echo sessions lasting an average of 90 minutes or so, provided 1,400 hours of training to these 282,000 people, and partnered with 32 different entities. And I'll just show you this. What the people they've trained is 206,000 frontline workers like community health workers, 40,000 physicians of all different specialties, 10,000 paramedical clinicians, nurses, pharmacists, 7,000 administrators. And 92% of these learners felt that the knowledge they gained was really helpful for their COVID response. In New Mexico, which is, we only have 2.3 million people, we've had 12,000 participants who've been trained on COVID-19 response. In Africa, so far, we've barely scratched the surface. About 6,600 clinicians trained. Our goal is to train 350,000 there in the next several months. And if you have that interest, reach out to me, as I've said before. Our partners in Africa are the World Health Organization, African Union, CDC Foundation, and Africa CDC. Africa CDC uses it for the global health security echoes. So what is next, of course, is that we are looking for partners. We will give you the resources. So what will we give you if you decide to partner with us for COVID-19 response or other echoes? For COVID-19 response, you will get all the technology that you need. You will get 3 days of training that you need to launch echoes, after which we'll provide you technical assistance. If you don't have the manpower to run an echo project, our team in India will help you run the projects in Africa. All you would have to do is bring your experts whom you want to democratize their knowledge, and it will be, and rapidly we can train tens of thousands of people or hundreds of thousands of people in so what you'll get is a highly experienced staff that will work with you to design, run, and echo sessions, experts in IT and Zoom. Of course, the Zoom licenses, we will extend our Zoom licenses to you, and we'll give you the software and tools for tracking, a cloud-based shared document repository where you will have information from all over the world from our 400 hubs, and ongoing support. What you would need to do is to buy into the idea on the left of democratizing the knowledge of experts. And you would need to tell us in your countries which types of knowledge need to be amplified, because COVID-19 is a very, very sensitive area for governments. They don't want foreigners to come in and start, telling the country what to do. But if to the extent that you need international experts, we will also help with that. Here is a 7-minute video, which I will not show you today, but Cynthia and my colleagues will send you this link. If you want to see an echo in action, please click on that YouTube link and you'll be able to see echo clinics in action. This is my contact information if you need to reach out to me, or you can reach out to Cynthia McKinney, and I will end here and open it up. We've left 23 minutes for comments and questions or discussion to see what you'd like to talk about, if this is of interest.
Dr. Arora, we do have a question in the chat. Can you elaborate on the duration of the COVID-19 response training? I understand each session is on an average 90 minutes, but how often do they recur, and are there ongoing case study component to it
Yes.
in each hub?
It is ongoing case in the beginning. When we are training before COVID-19 attacks a country really effectively, you could do some basic training. But once the cases start occurring, then people in the field need help. So we do that. This is a coalition of volunteers, doctors and nurses, and people come as long as they need trainings. Many of the programs are government programs where they will say, I want to train community health workers on 7 sessions of 2 hours each. Then that's what we do. Others will basically say, doctors, whoever need to care for their patients, come on, present patients. We call this process all teach, all learn. Everybody learns in the cases because everybody is having the same problems. And so there's a variety of things we use. Sometimes we'll bring international experts when they are required from the World Health Organization, the US CDC. Many times the governments adopt ECHO. For example, in India, the reason we were able to train 280,000 people in 12 weeks, because the Ministry of Health in India, in Delhi, the central ministry, and many state governments like the government of Maharashtra adopted ECHO model to use it as a platform to support their workforce. So there are all kinds of permutations and combinations possible. As long as you're interested, if you reach out to us, we can help you.
Great, thank you. Are there other questions or comments?
Hi, this is Katie Reynolds with Village Reach. Thank you for this fascinating look into what you've been doing. I do have some questions, and I think probably more can be answered offline, but I was curious if you had any learnings to share about how that model with community health workers has been working logistically. I know we often run into connectivity issues or there not being the technology or the hardware. I'm just curious if there's any creative solutions you've seen groups trying already.
Yeah, Katie, we've run many community health worker programs in the United States, in India, and other places. And here are some of the learnings. The first is, in countries in rural India or in Africa, for example, there will not be enough bandwidth to do video conferencing in these rural areas. So what we do for community health worker training is once a week, they travel perhaps half an hour to a clinic, a local clinic, which serves those communities. And they join forces, so 10, 15 maybe sitting in a room, and we have 20 such clinics connected. So we've got 200, 300 community health workers, and they are making a commitment, let's say for a training program for 12 weeks. Let's say what we've done, for example, is cancer prevention or cervical cancer prevention, early diagnosis of breast cancer, oral cancer. This is a program we ran in India. They would go to these places. In the Maharashtra government recently used ECHO very extensively for community health workers, for training contact tracers and all of that. And again, what was happening was they would come once a week to their local clinic where there was bandwidth. So there's usually within 15, 20 miles, something that essentially is available. And we connect all of these people together that way and train them. Now, in the United States, there is enough bandwidth, Katie, typically for us to do video conferencing, except in Native American tribes. But we need for our platform 3G or 4G. And that's how it works.
Very helpful, thank you.
Dr. Aurora, we have another question in the chat. You said during the presentation that we only work with universities and NGOs, nonprofits. Are you open to working with social impact companies?
Yes, we are. That was not a comprehensive list. We are willing to work with any single person in the world who has a common mission as us to help their communities.
Wonderful. And feel free to unmute yourselves and ask questions if you have them, or share updates. I think there might be somebody who'd like to share some updates.
I'm Ifeoma Okoye, and I work in the area of promoting clinical trials in Africa. I also do cancer advocacy, trying to reduce the late detection of cancer, cancers of breast, cervix, and prostate, specifically. So we work in communities, and we also run a treatment fund because our country, Nigeria, does not have a good insurance scheme. So what operates is out-of-pocket payments. So we try to raise funds to assist indigent patients to pay their bills. So essentially, that's what I do, trying to promote clinical trials across Africa. My organization, AGCPN, has been training and building capacity, both of the regulatory authority and the investigators, and also doing a lot of political will raising and community engagement for the past 14 years. Currently, I'm undergoing the globalizer training in order to scale our effort across Africa under a platform that we formed in 2017 called the African Clinical Trial Consortium. So that's my update. I'm also engaged with the Nigerian Center for Disease Control and the Nigerian Institute for Pharmaceutical Research and Development in the COVID response research, the COVID research response. So we are looking into developing different research areas to be able to bring answers to some of the issues surrounding COVID-19. And then specifically for the Nigerian Institute for Pharmaceutical Research and Development, we've started collecting candidates products from people who say that they have some natural remedies that will have impact in assisting to curb the COVID-19 pandemic. So we are looking into their products to authenticate the claims and then to see if we can find funding to run clinical trials on them. All right, thank you.
Thank you, Fiona, for those very kind comment and very, very interesting comments. I just want you to know we have a tremendous alignment of interest here and may be able to help you in many, many ways. I'm going to show you a slide of what we are doing for cancer across in many, many countries in the world, to the extent that if you have an interest in collaborating. So we have what I wanted to just essentially show you was we have echoes for smoking cessation, HPV vaccination, hepatitis B vaccination, sun safety, community cancer prevention, skin cancer, breast cancer, colorectal, oral lung, etc. But I want to show you clinical trial enrollment echoes, training clinical researchers across India. It's also in the US, cancer care navigation, precision medicine, palliative care, survivorship echoes. We also have many, many echoes related to advocacy, training advocacies, and in your case, echo could be helpful in your fundraising issues, fundraising efforts. So to the extent that you have that interest in partnering, I'm also an echo globalizer. I have a hard time articulating that clearly, but yes, since you were getting that training, I thought I'd let you know I'm a kindred spirit there, and reach out if you're interested in collaborating. Go ahead.
I'm very interested. How would I connect? How would I connect with you? Because most of these cancers you have mentioned, we've been working with them. Yeah, and then I actually forgot to say that as one of the templates that we are using, the model we are pushing across Africa is to develop what we call clinical trial units that are focused units in order to ensure that the quality of data that comes out in clinical trials in Africa, you know, is optimal and would also be able to, have industry confidence, increasing industry confidence to improve on the volume of clinical trials in the African region. So as the template is in my center, and it's called the University of Nigeria Center for Clinical Trials, and I'm the director of that center. So definitely, I would love to engage with you and know the different options. Okay, so I'm going to snap the screen now so that I'll get you. Yeah. Okay.
And it's in the chat too. Dr. Aurora's contact information is in the chat. And Dr. Aurora, we also have a question. Can you give examples of Project ECHO working with large health companies?
Mostly large health companies have partnered with us for the purpose of improving quality of care. So essentially what happens is, for example, a company is interested in an area. We obviously we don't ever want to become the marketing arm of a company. We are a purely social movement, okay? So we have to be very careful. There are no conflicts of interest. But often pharmaceutical companies or healthcare insurance companies that want to provide good healthcare to a very large population. So for example, if it's a health insurance company in New Mexico, they all partner with us for improving care in nursing homes or improving care in diabetes and so on and so forth, or improving access to hepatitis C treatment. And those are areas that we have collaborated with healthcare companies. Most of our collaborations, as we mentioned, have been with non-for-profits and universities, but more recently, there have been a significant number of organizations that have particular countries that they want to uplift the health system in, or particular disease areas. So for example, there is a large healthcare company talking to us about improving cancer care in Africa and some countries in Africa and Asia right now. And those are all the kinds of collaborations we have with large healthcare companies. Back to you, Cynthia.
Thank you, Dr. Arora. Again, if there are other questions or people want to talk about their work, feel free to unmute.
Yeah, one of the reasons why healthcare organizations like us, profit and not-for-profit, is that we have a very large network with learners in 158 countries. So for example, for Ifeoma, she was talking about a cancer network in Africa. We have learners in all 50 African countries. We partner with all the leading African organizations. And so what happens is, our interest primarily is to bring these stakeholders to table, start conversations, to create collaborative projects, and then use the ECHO model to disseminate the best practices, whatever they may be, whether they be in clinical trial enrollment or data tracking. So for example, with the World Health Organization, we have projects on data integrity. How do you, data for action? There are many, many such best practices that are not adequately amplified in the world, so that you develop a best practice in one part of the world, in one country or in one part of a country, but it doesn't spread. And so ECHO's primary contribution is to help you scale these best practices for global impact.
Wow. That is really profound.
Thank you.
I'm really excited that I attended this meeting to meet you.
Thank you.
Very, very God ordained. Thank you.
Anybody
Because
else?
we are just about to start up some series of online trainings for investigators, both on good clinical practice, ethics committee, training, protocol development, SOP development, systematic review, statistics, biostatistics, and pharmacovigilance. So I will talk to you more about it. Yeah.
Thank you. Anybody else has any question or comment?
Well, there was, it's not exactly a question, but I'm wondering if you could talk a little bit about ECHO as the ECHO model being used for prevention, early screening and diagnosis for patients at risk, in this case for NCDs.
Yes. So for example, it depends on who the learner is, of course, but in the United States and in India, etc., what happens is there aren't enough doctors. Doctors' time is so consumed with treatment that there isn't enough time for prevention. So in most countries in the world, in prevention, we often use either community health workers. In India, we use auxiliary nurse, midwife, or nurses. So what happens is, for example, in India, there are 3 cancers that are a particularly vexing problem. So one is cervical cancer. We know we have a treatment for it, right? This is absolutely not a treatment. We know we have a prevention, very effective, over 90% HPV vaccination. But there are a lot of social barriers. For example, many communities in India think that when a healthcare worker is coming to give an injection to them for HPV vaccination, they may be trying to sterilize this young woman so that she doesn't have babies in the future. So there is other concerns about for mothers for vaccinating their sons or daughters. Then there is this issue of doing pap smears and these kinds of things. They need training because these patients are very low income. They don't have the money to go to a hospital to get screened for cervical cancer. You have to take the screening to them. So you have to train people in the procedures. You have to train also in education to take the vaccine and so on and so forth. So that's cervical cancer. Breast cancer, what we do is, for example, the problem, we tackle the problem. The problem in India is that breast cancer is diagnosed very late in the disease. So what these community health workers, we train them to go and train patients on breast self-exam. They're all women. So that's an example of that. The third is oral cancer. Oral cancer in India, because they chew the betel nut, is a huge problem. So, but we know that if you stain the mouth with acetic acid, which is vinegar, what happens is if you have a pre-malignant lesion, then that will become white. We call that leukoplakia. And so what happens is you can train these workforce on simple diagnostic techniques to diagnose cancer early and refer into your system. So that's an example of that. In European countries, we train, and US, we train community health workers on sun safety because skin cancer is such a big problem. For NCDs, we have trained 150 community health workers in New Mexico alone on diet, exercise, smoking cessation, finger sticks, foot exams on diabetics, and so on and so forth. The idea is, what's the problem? What's the solution? How do you prevent this problem? Who is the workforce that is available in that local community to deliver the solution? And then we use ECHO's all teach, all learn model to train them, where the experts do the training, but the all teach, all learn comes into play because these community health workers feedback what are the challenges they're experiencing in the field and what solutions have they found. So this creates a virtuous learning cycle, which actually creates new knowledge. So ECHO is not a platform just to disseminate knowledge. It's a very key concept to take away from today's talk. ECHO is a platform to massively, exponentially scale the implementation of best practice, and whatever that may be, whether it be education or cancer screening or prevention of diabetes, etc. I have to leave, but I want to, my colleague Cynthia and will be on the call. Thank you all for joining, and thank you to Catalyst for giving me this opportunity to speak to all of you.
Thank you, Dr. Arora.
Thank you. Thank you so much.
And thank you all for joining. This has been great, and so many names that I recognize too. Great to see you all. And Catalyst 2030, thank you so much for your support and the important work that you do. Just a reminder, this was taped, and so this will be available in about 2 days up on the Catalyst 2030 site. Thank you, and we look forward to hearing from you.